presented in the US. The case was presented in the Washington state, and the investigation, and there was a document prepared by the Washington State 2019 NCOV case investigation team. So let us have that discussion. It is a very interesting and fascinating case. Plus, it also gives us an insight into how the doctors are managing mild cases, which are kind of moving towards serious, but not really serious. So mild cases of the coronavirus. So let's start. So I'm going to share my screen. So here is the document. So this document can actually be found online as well. Here it is. I'll post the links in the description. So this is the New England Journal of Medicine. This is the first case of 2019 novel coronavirus in the United States. So the basic history, the case report is, hey guys, welcome. Welcome, 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 welcome. So we have a very fascinating topic today, and that is a case report for the very first case that was presented in the US. The case was presented in Washington. So here on January 19th, 35-year-old man presented. So I'm going to skip some parts. I don't want to just read it. I want to make sure that we go through this and see how the patients were received, what were their symptoms, and then how the management was done, and what kind of labs were done. So I would like us to pay particular interest to the labs. So let's start. Very good morning, Ashish. Hey, Coco. Hey, Greg. Welcome back. Hey, Gaurav. And let's start. Let's start. So the patient was presented on January 19, a 4-day history of cough and subjective fever. So the patient had four-day history of cough and subjective fever. He had, my apologies for my cough, he had visited his family in Wuhan and had returned. So see here, January 15, after traveling to visit his family in Wuhan. And according to his history, the patient says that he did not come in contact with anyone who was in the Huanan market, the market where we think the virus started, the SARS-CoV-2. And he also says that he did not come in contact with anyone who was suffering from common cold-like symptoms. So with this, other than he had hypertriglyceridemia here, other than that, there is nothing remarkable about his general history. When he presented, his body temperature was 37.2 degrees centigrade, so about 98.7, I believe, degree Fahrenheit. Blood pressure 134/87, pulse was 110, respiratory rate was 16 breathings per minute or breaths per minute, and his oxygen saturation was 96%. So he was taking ambient air and he was 96% saturating. Lung auscultation revealed rhonchi and chest radiograph was performed. So here is his first chest x-ray. And if you see here, this is pretty normal x-ray. What you would see is that as he progresses within a few days, so 5th day of hospitalization, start paying attention to this part of his basilar part of his left lobe or lung, and you would see that the opacities would start appearing here. Then they would become bilateral. So keep an eye on that. So what they did was doctors took, and so patient actually said that because there is a guideline that people who have traveled to Wuhan or an outbreak area or have come in contact with someone who is COVID-19 positive and have symptoms, they should report. So he said, because I listened to that guidance, that is why I came in. So patient came in already saying that he is a suspected case. So what they did was they did a bunch of nucleic acid amplification tests on it to figure out if he had any other infection. And so here, influenza, A and B, parainfluenza, respiratory syncytial virus, rhinovirus, adenovirus, other common coronaviruses, which are human strains, these were all negative. Bhavan, I would talk the way I like. So if you don't like it, you can leave. So given the patient's travel history, the local and state health department, so what they did was they immediately informed the CDC, and they started, good morning, Manu. So they started the patient on as a suspected case, and they started working on him as a suspected case. So what they did was, the very first thing that they did was, with the CDC's guideline, they started collecting his specimens. So if you look at this guideline document here, let me actually open it. Role of this. Just one second. So this is a document that is by so this is the CDC's guideline. So over here they talk about the nasopharyngeal or oropharyngeal or nasal mid-turbine. So various kind of tests that can be, or swabs that can be taken. So back here to the discussion. So with the CDC's guideline, they took the nasopharyngeal swabs and they sent them over. Next day, so this was January 19. On January 20, the patient was declared positive. So yes. Hello, back to you from Washington. We are talking about the very first case from Washington that was in the US. So now on 19th, they sent the test. On 20th, he was declared positive, and they admitted the patient into the hospital. So patient started receiving basic supportive care. The only thing he was complaining of was intermittent cough, or dry cough, and intermittent fever. So on day 2 through 5, the patient's vital signs remained largely stable, apart from the development of intermittent fevers accompanied by the periods of tachycardia. The patient continued to report a non-productive cough and appeared fatigued. And this is a very interesting graph here. So what they've done is, this is where the patient got admitted in the hospital. And see here, the patient had fever, intermittent fever for these days. And look, he became feverless or afebrile on the day 7, but the cough continued. So the cough started on the day 1 and then continued till day 15. In that time, if you see, as he progressed in the hospital, he developed rhinorrhea, he developed fatigue. Then when he was at home, he had nausea and vomiting. So this is the interesting case here, that this patient not only has respiratory symptoms, but has a GIT symptoms as well. So he had the nausea and vomiting. And if you look here, on the first day, nausea, vomiting, and then second day, diarrhea and abdominal discomfort for 2 days, and then it subsided. Then he had nausea again on day 6. So that is again an interesting situation. Continuing. So what they did was, they kept doing the PCR test on him, and the test kept coming back negative. The supportive therapy here, antipyretic therapy with acetaminophen and ibuprofen. So 650 milligram of acetaminophen 4 hourly and 600 milligram of ibuprofen 6 hours. He also received guaifenesin for his continued cough. So that is, wow. So Sandra says, I'm an asymptomatic carrier, antibody negative. Are antibody tests reliable? No, so their sensitivity is really low. I don't see why the FDA has approved any antibody tests. So tell me that specific test that you're doing, and we'll have to see what is their sensitivity and specificity. They can vary. So back here, 600. So this is what was the supportive therapy, and throughout his 6 days of hospitalization, he received 6 liters of fluids as well. So see, antipyretics, antitussive, and painkillers with fluids. And if you see here, ibuprofen is here, which was supposed to have been not taken after that French minister's message that don't take ibuprofen, but this patient was given ibuprofen. Then what they did was, nature of the patient isolation until permitted only point of care. What they did was, day 3 and 5 reflected, look at this lab, leukopenia, thrombocytopenia, and elevated levels of creatinine kinase. What do you think is going on? So I'm going to go here to the labs. Actually, I'm going to open labs on his site. Tell me this. Patient has leukopenia, thrombocytopenia, and patient has elevated, what was the other one? Creatine kinase. What is going on? Tell me. So look, going back to this discussion here, leukopenia. Yes, definitely. So Sandra, the cytokine storm has not yet started. Good idea that the cytokine storm, but it is not yet started. Patient is not in that bad of a shape. So leukopenia and thrombocytopenia is basically, there is a inflammation going on. And so that inflammatory response during that process, of course, the thrombocytes are reducing. Why are they reducing? Because there is inflammation, and at the site of inflammation, there is fibrosis and there is clotting and there's coagulation. So that thrombocytopenia can be understood that way. Leukopenia is the white blood cells that are reducing, and that is one of the effect here in this infection, that the white blood cells or leukocytes start getting destroyed as well. And so maybe they are taking care of the inflammation, and in that process they are getting destroyed too, or maybe the virus is entering them and destroying as well. So the leukopenia is observed. Absolutely. Inflammation and exhausted immune cells. Absolutely correct, Yasmin. So with the creatine kinase, why do you think creatine kinase is going up? So creatine kinase is going up because the patient is now, you would see in a little bit that the patient is now becoming, is developing pneumonia, interstitial pneumonia, oxygen level are going to drop. And so he is going to start having some kidney function impact as well. So creatine kinase is increased. Hepatic functions, look at the hepatic functions. So alkaline phosphatase, alanine, AST, ALT, their ratio, of course, and then lactate dehydrogenase, all of these are elevated. And so if you see here in his, if you see here, aminotransferases, alanine aminotransferase, aspartate, alkaline phosphatase, they are all, so this is the normal range. Here, these are increased, and if you see, they kept increasing. So if you see here, there is an increase in them. So what happens? What does that mean? So Judy, I would not call it kidney failure. I would simply say that the renal system is impacted at this time. So with the liver levels, hepatic function levels, these are also raising. So that means there is some hepatic damage going on as well. And I hope we all are aware that in the case of liver, AST and ALT are interesting, and their ratio is also interesting. And please remember this, that ALT has an L in it, which is also like cytoplasm. Cytoplasm also has an L in it. ALT is an enzyme that is present mainly in the cytoplasm. And the AST is an enzyme that is present mainly or in abundance in mitochondria. So if there is a cellular damage, hepatic cellular damage, if that damage is just to the cell, then ALT will leak out more and you would have a higher ALT level. On the other hand, if there is mitochondrial damage or cellular damage with mitochondrial damage, for example, the cells are dying, then AST will be released as well. On the other hand, if the cellular damage is not occurring, ALT level may be low, but if the mitochondrial damage is occurring, for example, in alcohol or alcohol toxicity, then AST will be there. This is why we can say that with the alcoholic liver, the AST is greater than ALT. And with the viral, ALT is greater than AST because virus would kill the outer parts of the cell, leaking the ALT out from the cytoplasm, while alcohol is going to impact the mitochondria, leaking the AST out. Hey guys, how are you? So back here, if you see AST, ALT, alkaline phosphatase, they are all raised. Lactate dehydrogenase is raised as well, which is also an indication of the damage. Lactate dehydrogenase can be an indicator for damage throughout the body, but also is an indication of the damage to the liver. So given the patient's recurrent fever, so look, recurrent fever, not a stable, continuous fever. Given the patient's recurrent fever, blood cultures were obtained on day 4 and no growth was shown. So because patient had the recurrent fever, so of course, now let's say you have the viral infection, plus you still have fever, which is recurrent. So you would say maybe he's developing septicemia, or maybe he's developing enteric infections. So they started doing the cultures to figure out what other is happening. Thank you very much for the AST-ALT. Now, chest radiograph was taken on hospital day 3 and no evidence. So this was a chest x-ray, nothing special. Then a second chest x-ray radiograph taken on the day 5 and showed evidence of pneumonia in the lower lobe of the left lung. So if you see here, this is, I believe, the chest x-ray on day 5. So do you see that here in the lower part? If we compare it, so this is day 3. What day is this? This is day 3. So I just looked at it and looked normal, so I caught it. This is day 5. So compare these two. Compare this area here and this area here with this area and this area. Do you see? Let me see. Do it this way. Do you see that there are more opacities here compared to this area? So increasing left basilar opacity was visible, arousing concern about interstitial pneumonia. So now on day 5, so day 3, his x-ray was clear. Day 5, he started having the interstitial pneumonia. And this is, remember, one of the definitions of the serious cases is that the development of infiltrates within 24 to 48 hours. So here he is. Or oxygen saturation dropping below 93%. You would also see here that as he developed the chest x-ray, so day 5 showed evidence of pneumonia in the lower lobe of the left lung. And look at this, the same day, his oximeter measurement, oxygen measurement also dropped below 90. So from these two, he has now become a serious case by definition. The definition of the serious case from WHO is the serious case is when the heart rate goes above 110 plus the oxygen saturation drops below 90%, 93%, and the patient develops infiltrates within 24 to 48 hours. So within from 3rd day to 5th day, he went from breathing normally and 96% saturation to 90% saturation and needing oxygen. So on day 6, the patient was started on supplemental oxygen delivered by nasal cannula, and 2 liters per minute oxygen was given. They also, now they were afraid that he might develop, and this is young age, absolutely correct, Bhavan. This is young age. So given that they were also worried that the patient may develop secondary infections, nosocomial infections in the hospital, they started the patient on vancomycin and on cefepime. So vancomycin would cover what, and cefepime would cover what? Tell me. Correct. So cefepime is 4th generation cephalosporin, broad spectrum, both gram-positive and negative, and vancomycin would take care of the enterococci as well. So they have now started covering for any other secondary infections too. Yes. Okay, so on hospital day 6, on day 6th, chest radiograph showed basilar streaky opacities. So if I go down, I believe here it is. So look at this. Do you see those lines, these straight lines? These straight lines are the basilar streaky opacities. And these are indication of the interstitial pneumonia. So if you see here, chest radiograph showed basilar streaky opacities in both lungs, finding consistent with atypical pneumonia. Remember that the viral pneumonia is usually atypical, although this weird virus does something different. It starts with the atypical, and then, so let's say we make a few alveoli here. So these are the alveoli. And here, between the alveoli is the interstitium, correct? Virus normally, or viri normally, virus actually is a plural of virion. So virus normally cause interstitial pneumonia. And that is the interstitial pneumonia that shows up here, as you are seeing, ground glass appearance and the vertical streaky lines. So stable streaks. This particular virus then causes such massive inflammation that it moves from atypical pneumonia, atypical to typical, where there starts damage within the alveoli as well, and consolidation and fibrosis or organization starts occurring. There may be resolution as well, that some alveoli would become recovered, but it is possible that they become fibrosed and organized as well. So now we are having inflammation going on, atypical pneumonia going on, that is going to become typical, and then fibrosis and clotting happening here as well, which should give you some idea that what other labs will be interesting to look at. So if you see here now, look at this. Given the radiographic finding, the decision to administer oxygen supplementation to the patient's ongoing fevers. So one, he had oxygen need, fevers were ongoing, and then there were positive, multiple sites are positive. They had done tests on him from oropharyngeal route, I believe, and fecal route. Serum was clear, but fecal and oropharyngeal routes were positive. Very good. So somebody said D-dimers. So now what is going on is, so they're saying based on all of this and a period consistent with development of radiographic pneumonia in this patient, clinicians pursued compassionate use of, this is very important, investigational antiviral therapy, remdesivir. I remember that when I talked about remdesivir, that this may be something that is useful. And of course, people were using it. I got so many comments that, hey, who the heck are you? I get these comments all the time. But this was a special case where they said that you are trying to back the big pharma, and hydroxychloroquine can be a better drug, and you are asking for remdesivir, which is expensive. Here's the deal. Hydroxychloroquine in the early stages, in the prophylaxis, in the milder cases, that is an excellent drug and should be used there. Remdesivir, when the patient is becoming critical, patient has is progressing towards death now. So in that case, remdesivir is more effective than hydroxychloroquine. So it's not that I am for one drug versus another. It's just the stage of the disease may require a different kind of attack on the virus. So they started using remdesivir. And look at that. So this is day 6. And day 7, they saw that was initiated on the evening of day 7, and no adverse events were observed in association with the infusion. Then look at this. Vancomycin was discontinued on the evening of day 7, and Cefepime was discontinued on the following day after a serial negative procalcitonin levels and negative nasal PCR. So check this out. I really, absolutely well done. They took care of the patient so nicely. So yes, tell me how procalcitonin was necessary. Why do they say that, hey, we checked procalcitonin to decide to stop the antibiotics? Why do you think they did that? See here, they're saying vancomycin was discontinued on the evening of day 7, and Cefepime was discontinued on the following day after serial negative procalcitonin levels and negative nasal PCR testing for methicillin-resistant staphylococci. So tell me the importance of procalcitonin. So look, procalcitonin test was approved by FDA in 2017. This is, of course, we know that in the thyroid, procalcitonin is also present and it becomes calcitonin. Interestingly, yeah, absolutely, Tariq, very good. Interestingly, what is important is that procalcitonin is increased in bacterial pneumonias or bacterial infections and sepsis, including pneumonia in our case here. And this is not increased in viral pneumonia or in other respiratory syndromes. So it has 91% sensitivity and 90% specificity for bacterial infections or sepsis. Because of that, and just very quickly, we show you here, this is interleukin 1, 6, acute phase protein. So this is procalcitonin. So if you can read this one up, but this has a 90% sensitivity and 91% specificity for the bacterial infections. And so because of this test, we have now, we can decide when not to give antibiotics if the inflammation in the lungs is for some other reason, for example, by virus or some other autoinflammatory issues or autoimmune issues. So it causes the prevention of overuse of antibiotics. Plus, it helps with the mortality as well, to reduce the mortality. So very, very good things here. So they discontinued the antibiotics. They started the patient on remdesivir on day 7. On hospital day 8, the patient's clinical condition improved. Supplemental oxygen was discontinued. Beautiful. I love it. Oxygen saturation went back to 94 to 96% while he was breathing ambient air. The previous bilateral lower lobe rails were no longer present. His appetite improved and he was asymptomatic aside from intermittent dry cough and rhinorrhea. So this is the basic, absolutely. So there's a question here that is, could you explain the difference of COVID-19 pneumonia and bacterial pneumonia? Thanks a lot. So basic, just a very high level. I wanted to make sure that today we are short as well, but look, if we have, this is a lung, and let's take an airway. So let's say this is the airway, and I'm just going to make, for my purpose, 2 or 3 alveoli here. These are the alveoli. We have 2 types of pneumonias, typical or bacterial and atypical or viral. Atypical, if I know the spelling, that will be awesome. Atypical or viral. And this is bacterial. Bacterial pneumonia generally is within the alveoli. What happens is, we know that within the alveoli we have type 1 pneumocytes and we have type 2 pneumocytes. Correct? So type 2 pneumocytes are responsible to make type 1 pneumocyte and surfactant. Type 1 pneumocyte are responsible to take care of the respiratory membrane, or they are part of the alveolar membrane through which the gaseous exchange occurs. We also have in the alveoli macrophages that are the first responders to the infective agents or allergens coming into the alveoli through the air. So when the infection occurs in this area, in the alveoli here, within the alveoli, that is usually called typical, and that is usually bacterial. The damage that happens is, so it's a large discussion. I've done many, many lectures about it. If you read through, if you search in my channel on YouTube, you can see typical pneumonia and atypical pneumonia. Atypical is viral and typical is bacterial, and I've done the mechanism there. But generally what happens is, when the inflammation occurs within the alveoli, then the alveoli start becoming congested with the inflammatory exudates. There are cytokines here which would leak out, which would cause vasodilatation. So this whole area would start becoming inflamed and edematous. Normally, typical pneumonia would either become organized, which means that this area would become fibrosed and this alveoli would shut down and the lung would be damaged forever over here. Or it would become resolved, which means that the damage or damaged pieces are picked up by macrophages and the alveolus goes back to normal functioning. Now, this is typical bacterial pneumonia. On the other hand, viral pneumonia is in the interstitium. That is a connective tissue between these alveoli. And I'm sorry, my cat is playing with her toys. So this is the alveoli. And when the infection occurs here, that is called atypical. The reason that the infection is called atypical is that it does not cause productive sputum. When the bacteria causes infection and that infection is sitting in the alveoli, this gunk that is produced here, this pus that is produced here, which has edematous fluid or exudates plus broken macrophages plus broken pneumocytes plus other inflammatory cells plus the pathogen, all of that trash, when that is brought up through the mouth, this is the sputum. And so we call this kind of a cough, productive cough, which brings up this trash as well. On the other hand, when virus does the infection, it sits outside of the alveoli. So when the patient coughs, it is a dry cough and there is nothing that is coming out of the alveoli because alveoli are clear. But when you take an X-ray, a radiograph of this patient, you would see the ground glass appearance and you would say, oh man, this guy has infiltrations here. But the person would not even know that something is going on. And this is why we also call viral pneumonias as walking pneumonias. Patient who is going to walk in and then patient would be revealed if you did some chest auscultations or if you did the radiograph, and patient would reveal to have pneumonia. Now, in case of COVID-19, it starts with the atypical pneumonia. That is why the shortness of breath, because the respiratory membrane, so remember the respiratory membrane or the gaseous exchange membrane has, if I make one more alveolus here, this is an alveolus, this is a blood vessel. So between the alveolus and if oxygen is here and wants to go here in the blood vessel, what does it have? It has pneumocyte type 1 or pneumocyte type 2 that is on its way to cross. Then it has the interstitium that is on its way to cross. Then it has the endothelium of the blood vessel that is on its way to cross, and finally the plasma and then the RBC. So this is the membrane through which oxygen has to travel. And when the virus, let's say COVID-19, comes in and causes issues here at the respiratory interstitial level, that causes oxygen travel to become difficult. And this is why the shortness of breath is done. This would happen in bacterial pneumonia as well, but in that case, the trash is present inside the alveolus itself and less is outside, but still the oxygen travel is still difficult. So they both would have shortness of breath. One would have productive cough and the other one would not have productive cough. So COVID-19 starts with the interstitial pneumonia, then it progresses, it causes such a large reaction of inflammation, such a big trigger of inflammation that it becomes typical pneumonia and it causes the congestion to the point that almost the whole lung becomes inflamed and edematous, which is the acute respiratory distress syndrome. So not only it goes from typical to atypical to typical, it progresses to ARDS. From there, it progresses to septic shock, which is vasodilatation. And I've done a video called Why COVID-19 or SARS-CoV-2 kills so fast. And I've discussed this whole mechanism in there. So it causes septic shock and death. So this virus does not play by the rules of a virus to stay interstitial and then go away from there. It progresses to typical, then it progresses to ARDS, then it progresses to septic shock, and then to the death. So this is the discussion today. I hope that this is interesting. So in the beginning, they did the symptomatic treatment with the antipyretics, with the painkillers, and with antiemetics. They also gave transfusions. Then they put the patient on oxygen. Then they started patient on remdesivir, and next day patient started improving. So this is the discussion. Any question? Tomorrow I will take an off. Please do me a favor, share this with your friends, and we will continue day after tomorrow. So let's see some of the, so Carol says terrible, absolutely. Jamie says, what about the folks coming in with very, very low SpO2 but no dyspnea? Oh, so one more thing. And that is possible. I totally understand what you're saying. I want to show you one more thing that I forgot to show. And that is in the labs. Here in the labs, I wanted to ask you guys, so fibrinogen levels increased in this person. Why did they increase? Fibrinogen levels increased in this person. Why did they increase? That is your question. So can you respond to that in the comments? I would then look at the responses and explain why the fibrinogen levels were increased. So how is the effect of COVID-19 in advanced stage as different than DIC? No, so it actually takes us towards DIC. So hypercoagulability is the first state, and then DIC can occur. Yeah, that is true. Ambulance workers, all healthcare workers can have a higher load. So you're most welcome. Steroids, according to a study, steroids were supposed to reduce the clearance of the virus from the respiratory tract. So WHO did not recommend steroids. But I think that the steroids should be used whenever it is necessary, that the steroid, so you have to look at the patient and decide if it is necessary. And of course, there is a triage you will do, but steroids generally are contraindicated. Absolutely, totally agreed that we should continue to work on hydroxychloroquine as well. All right, guys, thank you very much. Please put your comments out. What would you like next? I was planning to do asthma and pediatrics. So maybe on Monday we do pediatrics and COVID-19, and then asthma and COVID-19. But if you would like more cases, I have some cases as well, which are critical and serious cases, and how they managed those, and how did they manage the interleukin, the cytokine storms and those. We can discuss those as well. Okay, awesome. So please comment. Number one, my question to you, please provide a comment for that, and then any comment for what should we do on Monday, maybe pediatric or maybe asthma, and then we'll go from there. Thank you, and stay blessed. Talk to you later. Share, please. And if you have not subscribed to the YouTube channel, please subscribe. Thank you. Bye-bye. I'm not a very big salesy person, so this is all I can say.